Good day, everyone. For this week's lecture, we will be discussing the latest infection control guidelines from the Ministry of Health regarding coronavirus disease. The COVID-19 guidelines were done with the best available data and evidence. These guidelines will be updated as more information becomes available. Just a quick background of our COVID-19 disease. When we talk about coronaviruses, these are a large family of RNA viruses that causes illness ranging from the common cold to more severe diseases such as Middle East Respiratory Syndrome or your MERS-CoV and severe acute respiratory syndrome or your SARS-CoV. The new strain of coronavirus was identified in December 2019 in Wuhan City, Hubei province of China, and has been named by the International Committee on Taxonomy of Viruses, or ICTV, as Severe Acute Respiratory Syndrome Coronavirus 2. The ICTV have determined that SARS-CoV-2 is the same species as SARS-CoV, but a different strain. The WHO, or the World Health Organization, has named the disease associated with SARS-CoV-2 infections as corona or COVID-19. Since the emergence of the 2019 novel coronavirus infection in Wuhan, China, in December 2019, it has rapidly spread across China and more than 200 other countries. Most of the cases involved in the first cluster in December 2019 were linked to the large Wuhan seafood market. The original source of SARS-CoV-2 transmission remain unidentified. However, available genetic and epidemiological data suggests that SARS-CoV-2 is a zoonotic pathogen with possible spillover directly from wildlife or via intermediate animal hosts or their products. Sustained human-to-human transmission has been confirmed in China, where numerous healthcare workers have been infected in clinical settings with overt clinical illness and fatalities. Most cases have been associated with fever and respiratory symptoms like coughing and shortness of breath, while other cases are mild or subclinical cases. However, there is not much information about SARS-CoV-2 to draw definitive conclusions about transmission mode. Transmission of the virus mainly through droplets mode, less frequently through contact. It can be transmitted as well through aerosol in case of aerosol generating procedure in close contact in indoor setting. Investigations are currently in progress. Some people may transmit the virus despite being asymptomatic. However, researchers do not know how often this may happen. The objectives of this lecture is, first is to provide guidance on infection prevention and control practices to be implemented when managing suspected and confirmed COVID-19 cases, standardize the clinical management of COVID-19 patients, and lastly is to provide guidance on COVID-19 surveillance in healthcare and community settings. As you can see on the screen is we have the definition of COVID-19 suspected cases. Your suspected cases is divided into two columns. We have the first one is your clinical presentation, then the second one is we have your criteria. The first clinical presentation of our suspected case of COVID-19 is we have patient with acute respiratory illness, sudden onset of at least one of the following. We have fever, measured or by history, cough, or shortness of breath. Then there is no criteria required for this first clinical presentation. As long as the patient is showing the mentioned signs and symptoms, then he or she is considered to be a suspected case of COVID-19. The second one is we have patient with sudden onset of at least one of the following. We have headache, sore throat, rhinorrhea, nausea, diarrhea or loss of smell or taste. And in the 14 days prior to onset of symptoms, met at least one of the following criteria. So when the patient is exhibiting these kinds of signs and symptoms, you should correlate it with the following criteria. First is, had contact with a confirmed COVID-19 case in the last 14 days prior to onset of the symptoms, or working in or attended a healthcare facility where patients with confirmed COVID-19 were admitted. So that is the second clinical presentation. The third clinical presentation is we have any admitted adult patient with an explained severe acute respiratory infection or SARI, either community-acquired pneumonia or hospital-acquired pneumonia. So that's the last clinical presentation, and it has no required criteria as long as the patient is presenting or exhibiting those kinds of case, then he or she is considered to be a suspected case of your COVID-19. On our second case definition of COVID-19, it is mentioned there as part of its criteria that the patient had contact with a confirmed COVID-19 case. Now, how do we define contact? It is anyone with any of the following exposure. First is being within a 2 meter of a confirmed COVID-19 case for greater than 15 minutes. Second, direct physical contact with a confirmed COVID-19 case. Providing direct care for a confirmed COVID-19 patient without using proper personal protective equipment. Living in the household with a confirmed COVID-19 case. Sharing a room, meal, or other space with a confirmed COVID-19 case. Sitting within 2 rows in any direction of a confirmed COVID-19 case for greater than 15 minutes, and any crew in direct contact with the case in a public or shared transportation. If we have definitions of a suspected case of COVID, we should also know what a confirmed COVID-19 case is. A confirmed COVID-19 case is a person who is confirmed by a nucleic acid amplification test or your PCR by a certified clinical laboratory which is authorized by public health authority, or a person who meets suspected case definition and tested positive by a RDT kit that is authorized by SFDA and validated by public health authority. Your RDT, it is a rapid diagnostic test. It is a medical diagnostic test that is quick and easy to perform. We know that some of the healthcare workers who have COVID before, even last year, still contracted COVID-19 up to this time. So we sometimes call that as your COVID-19 reinfection. There were many reported cases of COVID-19 reinfection around the world until now. Cases were relatively young and immunocompetent. The clinical presentation differed between the cases. While most were asymptomatic, others showed mild to moderate symptoms that required hospitalization. A concrete definition of a COVID-19 reinfection is at any point in time, you get infected with a COVID-19, although you have been infected before, but the isolated virus found by gene sequencing is different from previous infection that has been isolated. So that is a confirmed case of reinfection. Meaning to say, the virus that has been found currently is different from the one that is seen before. So let's discuss now what are the infection prevention and control guidelines or measures that we need to partake in order to prevent or control the transmission of COVID, especially in the healthcare settings. The first principle of infection prevention and control strategies associated with healthcare who suspected COVID-19 are: first is we have your early recognition and source control. To be able to recognize, especially at the point of entry, and to provide source control of any transmission in our healthcare institution, we need to educate and encourage the healthcare workers to have a high level of clinical suspicion. How? Of course, they should be knowledgeable about the suspected case definition of our COVID-19. Next one is we have the activation of our respiratory triage. So in the hospital, at the point of entry in our emergency room, we are already triaging all our patients, especially those who are exhibiting any signs of respiratory symptoms. The other one is we have post signage reminding symptomatic patients to alert healthcare workers, promotion of our respiratory hygiene as an important preventive measures. So for us healthcare workers, we need to educate also our patients, especially those who have respiratory signs and symptoms, to observe cough etiquette at all times. And suspected COVID-19 patients should be placed in an area separate from other patients, and additional infection prevention and control precautions promptly implemented. So we have waiting areas, we have acute respiratory illness areas, as well as our negative pressured rooms, or our airborne infection isolation rooms for those suspected cases of COVID-19. The second strategy is we have the application of standard precautions for all patients. Standard precautions include, first is we have a universal masking, which is a mandate from the Ministry of Health, so everyone should wear a mask. Correct and consistent use of available PPE and appropriate hand hygiene, of course, which is very important. Perform hand hygiene after contact with respiratory secretions. PPE effectiveness depends on adequate and regular supplies and proper selection of our PPE. Now, we have PPE that is very important to wear depending on the case of our patient. Okay? If the patient is on droplet, contact, or airborne precaution. Next is we have ensured that environmental cleaning and disinfection procedures are followed consistently and correctly. Manage laundry, food service utensils, and medical waste in accordance with safe routine procedures. So since we started, or since pandemic started, we are giving, especially for the food services, the utensils, they are using already disposables instead of the one that we are using before the pandemic started. And lastly is prevent needle, stick, or sharps injury. The third strategy is we have the implementation of empiric additional precautions. Now, this includes contact and droplet precautions for suspected COVID-19 cases. Now, there is a memo that was released by the Infection Prevention and Control Department changing the precautions that we're going to apply for suspected and confirmed cases of our COVID-19. Before it was airborne, now we are putting it on droplet precautions, especially for those patients not requiring aerosol-generating procedures. Place patients in adequately ventilated single rooms. It is preferred and strongly recommended not to cohort suspected COVID-19 patients because it carries a risk of transmission of infection between patients if one of them will be confirmed. In cases of severe shortage of single rooms, it is possible to cohort suspected COVID-19 patients together with the strict adherence of the following standard. First, one patient only should be admitted in each multi-bed room. Second, there must be a physical separation between the patient's bed, like single-use curtains, mobile or fixed partitions. Third, it is strictly forbidden to implement aerosol-generating procedures if we're going to cohort patients. If the mobile HEPA filter devices are available, a device can be placed between each of two beds. Moreover, for the implementation of empiric additional precaution is strict adherence by healthcare workers to infection control practices, which is very important because infection control is everyone's responsibility. Never share the patient care equipment between patients. As much as possible, try to dedicate patient care equipments for a specific patient. But if you cannot dedicate, try to, as much as possible, clean it or disinfect it before using it with another patient. Third is patients should be asked to wear surgical masks throughout their hospitalization period. They are required not to move in the rooms between beds and corridors. Use a surgical mask with an eye or facial protection like goggles or a face shield. Use gloves and a clean, non-sterile, long-sleeve, fluid-resistant isolation gown. Now, as part of our transmission-based precautions, when we talk about contact and droplet precautions, the two most important PPE for contact is we have your gloves and your gown, while for droplet is we have your surgical mask. So your PPE, as what I have mentioned during orientation, is based on your risk assessment. Moreover, we need to remove our PPE after caring for a patient in a proper way, then dispose it. After that, we need to perform hand hygiene and use either single-use disposable equipment or dedicated equipment, as what I have mentioned earlier. Refrain from touching eyes, nose, or mouth with potentially contaminated hands. So after you have touched any items or surroundings, or after touching your patient, or if you feel that your hands is dirty, or if you are in doubt, try to perform hand washing or hand hygiene first before you touch any parts of your face. And avoid the movement and transport of patients out of the room or area unless medically necessary. And use designated portable X-ray equipment and or other important diagnostic equipment. Now, if transportation is really required, as for example, if the patient requires CT scan or MRI, you can perform all those procedures in the patient's room, correct? So the things that we need to do is, if we are going to transport patient outside of his room, notify the receiving area of what is the precautions that they're going to apply or the case of the patient. Use predetermined transport routes. Use routes that has less encounter with other patients or visitors. Transferred patients should not wait in the waiting area or recovery room. Isolation signage should be hanged to the patient transportation equipment. Ensure that healthcare workers who are transporting patients wear appropriate PPE. So depending on the case of the patient, if it's contact droplet or airborne, healthcare workers should also wear appropriate PPE. Routine clean and disinfect patient contact surfaces with OH approved disinfectant. Lastly, for the implementation of empiric additional precautions is to limit the number of healthcare workers, family members, and visitors in contact with a patient with suspected COVID-19 infection. Maintain a record of all persons entering the patient's room, including all staff and visitors, including communication tools like mobile number. So we have isolation log sheet forms that everyone should fill out if they are going to get inside the patient's room. In addition to the empiric precautions of our COVID-19 is we need to apply airborne precautions for aerosol generating procedures for suspected COVID-19. How? First is, if you will be performing AGP, you need to have a fit-tested particulate respirator that fits for you with your correct size and model. Always perform the user seal check when putting on a disposable particulate respirator. Now, for your nasopharyngeal swabbing, in case of non-availability of a respirators, the healthcare worker can use surgical mask and face shield during the process. Fourth one is healthcare workers should avoid performing AGP if all types of respirators does not fit to him during fit testing procedure. So he or she should wear a PAPR or your powered air purifying respirator. Use eye protection like goggles or your face shield. Clean, non-sterile long-sleeve isolation gown and gloves are used. If gowns are not fluid resistant, use a waterproof apron for procedures with expected high fluid volumes that might penetrate the gown. Perform procedures in a negative pressure rooms with at least 12 air exchange per hour and control direction of airflow when using mechanical ventilation. In case of unavailability of negative pressure room, nasopharyngeal swab could be taken in a well-ventilated single room with portable HEPA filter. Then lastly, limit the number of persons present in the room to the absolute minimum required for the patient's care and support. So if you are not part of the patient's care or a specific procedure, then do not go inside the patient's room. The next IC strategy is management of exposure to COVID-19 in healthcare facilities. To determine the time period that the confirmed COVID-19 patient or healthcare worker could be infectious for proper contact tracing, first is for confirmed COVID-19 healthcare workers or patients who develop symptoms, consider the exposure window to be 2 days before symptom onset. Now, for this case, we need to do contact tracing for those people who came in contact with this person for the last 2 days before the onset of symptoms. The second one is for confirmed COVID-19 healthcare workers or patients who never developed symptoms. They should be considered potentially infectious beginning 2 days after their exposure. If the date of exposure cannot be determined, use a starting point of 2 days prior to the positive test result. So it's just the same with the first case. Any patient who came in contact for the last 2 days with a confirmed case, we need to do contact tracing for all those people. On the slide is the epidemiologic risk classification for healthcare workers following exposure to patients with COVID-19 or their secretions or excretions in a healthcare setting and their associated monitoring and work restrictions recommendation. So there are 4 columns. On the first column is we have your epidemiologic risk factors. The second one is we have your exposure category. The third one is recommended monitoring for COVID-19 until 14 days after last exposure. And the last one is we have your nasopharyngeal swab if it's required, and if it's required or not, and work restrictions for healthcare practitioners. Under your epidemiologic risk factors for healthcare workers wearing PPE, protected with complete PPE, and wearing only face mask or respirator, this is considered as a low exposure category. The recommended monitoring for this one is self-monitoring, meaning to say healthcare workers will be the one who will monitor for their signs and symptoms, and they will just inform the assigned personnel if they develop signs and symptoms. And if asymptomatic, a healthcare worker must apply universal masking and continue his or her duties. If symptoms appear regardless to vaccination status, healthcare worker must refrain immediately from clinical duties and report infection control. For healthcare workers who are not wearing a face mask or respirator and not wearing all recommended PPE like your respirator, face shield, gown, and gloves during AGPs for any duration of time, it is considered as a high exposure category. Now, for this type of exposure, we need to do an active monitoring. When we talk about active monitoring, this is a regular communication with potentially exposed people to assess for the presence of fever or respiratory symptoms. Now, all healthcare workers of high-risk exposure can continue their work with strict adherence to universal masking during their presence in the healthcare facility, even in their lounge during break times, as long as they are asymptomatic. If symptomatic within 5 days, test and isolate accordingly. When can a healthcare worker can return to work after he or she is being infected with COVID-19? Well, it depends if there is shortage of staff or none. If there is no shortage in staff who has been symptomatic, he or she should have the following criteria. 7 days have passed since the start of symptoms. Any healthcare worker who care for long-term care or immunocompromised patients are preferred to be tested by RDT without confirmation with PCR. Now, for those healthcare workers, since from the beginning that he or she was confirmed to have COVID-19 is asymptomatic, 7 days have passed since the test was taken and no symptoms appeared during the period. If there is a shortage of staff, it could be categorized as severe or moderate. If there is a severe shortage of staff, healthcare workers may continue their duty if they are able to. Healthcare workers should adhere to universal masking during their duty, and affected healthcare workers should minimize their exposure to other colleagues as much as possible. That is for severe shortage of staff. Now, if there is a moderate shortage of staff, symptomatic healthcare workers, 5 days have passed since the start of symptoms. Healthcare workers who care for long-term care or immunocompromised patients are preferred to be tested by RDT without confirmation with PCR. And for asymptomatic healthcare workers, 5 days have passed since the test was taken and no symptoms have appeared during the period. Next infection control strategy is administrative controls, which is very important also with the support of the hospital administration. First is there should be an adequate staff training and specifically appropriate human behavior and patients' caregivers education. So, as what I have mentioned, that infection control is everybody's responsibility, and your behavior towards preventing and controlling infection is very important. And it is also very important as well to educate our patients with the right tool in order to prevent or to control transmission of infection in the institution. Next is staff that manages suspected or confirmed cases should be chosen based on their immunization status as much as possible. So I think most of our healthcare workers, especially nurses and doctors, have received already the 2 doses of the COVID-19 vaccine. And it is mandatory to take booster shots also. Policies on early recognition of acute respiratory infection potentially due to COVID-19. So we have policies and procedures, infection control policies and procedures for COVID-19, and as well as the basic of infection control and prevention. Access to prompt laboratory testing for identification of the etiologic agent, prevention of overcrowding, especially in the emergency department, provision of dedicated waiting areas with clear signage of respiratory waiting area for symptomatic patients, and appropriate placement of hospitalized patients, promoting an adequate patient to staff ratio. So in ER, we have dedicated respiratory waiting area for those that has been suspected with COVID-19 or those patients who are exhibiting respiratory symptoms. And we also have guidelines and policies for any patients that is admitted due to COVID-19 or suspected to have COVID-19. Next is we have provision and use of regular supplies, which is very important. Monitoring of healthcare worker compliance with standard precautions along with mechanism for improvement as needed. The next strategy is we have the environmental and engineering controls, which is also an important aspect in preventing and controlling transmission of infection, more specifically with COVID-19. First on the list is we have ensuring adequate environmental ventilation. So we have HEPA filters, we have airborne infection isolation rooms or your negative pressured rooms. Next is we have adequate environmental cleaning in all areas within the healthcare facility. Terminal room cleaning at the time of discharge or transfer of patients. Physical separation of at least 1.5 to 2 meter distance should be maintained between each patient, between each suspect patient and others. The next one, as part of our strategy in infection prevention and control, is collection and handling of laboratory specimens from patients with suspected COVID-19. All samples collected for laboratory investigations should be regarded as potentially infectious. Okay? Healthcare workers who collect or transport clinical specimens should adhere rigorously to standard precautions. So, appropriate use of your PPE and basically your hand hygiene. Ensure that healthcare workers who collect specimens use appropriate PPE, as what I have mentioned. The respiratory specimens should be collected under aerosol generating procedures. Personnel should wear a particulate certified N95 respirator. Ensure that all personnel who transport specimens are trained in safe handling practices and spill decontamination procedures. Place specimens for transport in leak-proof specimen bags that have a separate sealable packet for the specimen with the patient's name label on the specimen container and a clearly written laboratory request form. So we have a swab label, package form, and as well as your shipment forms for all the specimens that we are transporting to the Riyadh Regional Laboratory. Deliver all specimens by hand whenever possible. Do not use pneumatic tube system to transport specimens. We also have the environmental cleaning and disinfection after suspected or confirmed COVID-19 patients in the facility. For inpatient rooms, it should be cleaned and disinfected at least daily and at the time of patient transfer or discharge. More frequent cleaning and disinfection may be indicated for high-touch surfaces and following aerosol-generating procedures to surfaces like the tables, hardback chairs, doorknobs, light switches, remotes, remote handles, desks, toilets, or sinks. Those are your high-touch surfaces. Cleaning staff should wear disposable gloves, surgical masks, and isolation gowns for all tasks in the cleaning process, including handling of waste. Cleaning and disinfection of the environmental surfaces should be with the approved MOH disinfectant like your hydrogen peroxide, which we have, quaternary ammonium chloride, fourth generation, freshly prepared sodium chloride solution with consideration to the contact time in accordance with manufacturer's instruction for environmental surface disinfection. And after patient transfer, terminal cleaning should be done using manual method or ultraviolet germicidal irradiation or hydrogen peroxide dry mist or vapor. Now, we also have guidelines in infection control in radiological examination for suspected or confirmed COVID-19 cases. So, chest x-ray for patients with suspected or confirmed COVID-19 should be done at the patient room with portable machine as much as possible. So, we have discussed a while ago that any diagnostic procedures or transporting of patient outside his or her room should be done only as necessary. Imaging patients with suspected confirmed COVID-19 should only be considered for emergent situation. Transmission-based precautions of contact, droplet, and or airborne infection should be applied with suspected or confirmed COVID-19 patients depending on patient status and the procedure. Portable radiographic machine should be used as much as possible. So we have dedicated X-ray machine, portable X-ray machine in the ER. And if the patient is, as well as in the ward, it should be highlighted in the imaging request that the patient is suspected or confirmed COVID-19. So in the ER, healthcare workers or nurses are informing the technician that this is a suspected case of COVID-19. The radiology technician should be trained from infection control department about standard and transmission-based precautions, especially hand hygiene, proper selection and use of PPE. Portable machine should be disinfected after use with approved MOH disinfectant and according to the manufacturer's recommendations. Furthermore, we have infection control guidelines for suspected or confirmed COVID-19 in the radiology department. Now, if the portable machine is not available or cases requested for static machine and or advanced imaging procedure, the referring physician should discuss the case with the radiology consultant in infection control department before sending the patient for imaging. The patient should be directly taken into the modality room without delay and should not be waiting in general waiting area of the department. The modality scan area should be clear of other patients and or unnecessary staff. So limit number of people inside the room where the procedure will be done. Items or equipment that are not needed in the examination should be cleared. So only those items or equipment that is necessary for the specific procedure should be available in the patient room. Radiology staff should don the necessary PPE when dealing with the patient and doff them after the finish of the process. Next one is we have the laboratory diagnosis. For collecting samples, the lower respiratory tract samples are preferred if patients have signs or symptoms of lower respiratory tract infection. If lower tract specimens are not possible or clinically indicated, upper respiratory samples should be collected. For adult patients, whenever feasible, nasopharyngeal swab should be the first choice when collecting samples, followed by if nasopharyngeal swabbing is not feasible, nasal wash or aspirate can be considered. So as you can see on the slide, there is arrow going down. So the first thing that we need to consider in collecting sample is we have the nasopharyngeal swab, followed by the nasal wash or aspirate. And if the two other options are not feasible, then we will be collecting it through oropharyngeal. While for children less than 12 years old, oropharyngeal swab should be considered. So it's just a reverse compared to your adult. If not feasible, nasal wash or aspirate can be considered. And if the two other first two options is not feasible, nasopharyngeal swab can be considered. Only flexible nasopharyngeal swab should be used. As you can see on the slide, the two collection site, we have your nasopharyngeal swab and your oropharyngeal swab. So we're going to check the difference, especially for the swab kits. For nasopharyngeal swab, proper selection of sample collection stick. Stick tends to be thinner towards the tip. Avoid using stick with indentation closer to the tip. So I think most especially for those who are taking samples, if you are going to take sample through nasopharyngeal or nasopharynx, you will see that the stick is less thicker compared to oropharyngeal, especially the tip. and it is more flexible compared to the stick in oropharyngeal swabbing. As compared to oropharyngeal swab, stick tends to be thicker than nasal with larger tip. So nasopharyngeal, less thicker, especially the tip, while oropharyngeal, it's more thicker, especially the tip. So this is the visual triage checklist for acute respiratory infection. This is what we are using now in the hospital. So if you score the patient 4, you need to ask the patient to perform hand hygiene, wear a surgical mask, although universal masking is applied, direct the patient through the respiratory pathway, and inform the doctor for assessment. For MERS-CoV or COVID-19 testing should only be performed according to the case definition. So this is the algorithm for our COVID-19. So patient arrival, offer surgical mask, ask patient and company to perform hand hygiene. If with obvious respiratory symptoms, then do your visual triage checklist form. If score is less than 4, direct patient to ER or OPD after acute respiratory illness is ruled out. If score is more than or equal to 4, maintain medical mask, perform hand hygiene, assist patient to airborne infection isolation room, evaluate and assess patient, notify infection prevention control department, perform nasopharyngeal swabbing, decide disposition whether home isolation or admission. If the patient is for home isolation, instruct on guidelines for home isolation while waiting for the result. Advise to seek medical care as soon as possible if patient develops worsening respiratory illness. And if for admission, place in AIIR until result is in, or you can place the patient in a single room with a portable HEPA filter if the patient does not require AGP. So that ends our lecture for this week, which is the infection control guidelines for COVID-19. So if you have any questions, just type your questions on the next item after this video presentation. Thank you and hope you have learned something. See you on our next lecture.